So welcome back to the Critical Care Symposium Conference 2024. I'm joined by Rob MacSweeney. Now, Rob has been one of my heroes for a long time. I first got in touch with Rob, it's got to be 10 years ago, when he was producing a newsletter, and I asked him for some advice as to how to do the same. You know, you fire these emails off and you don't really expect a reply, but dear Rob sent me a whole list of things that I should be doing, and he's been my hero ever since. So Rob also runs the Critical Care Reviews conference over in Belfast, where he gets some of the big players with the big studies to come over at the Titanic Centre now.
Titanic Belfast, that's right.
Yeah. And it's been going for how long?
Oh, I think this year must be our 12th maybe.
Right, okay.
So,
Is it getting bigger?
It is getting bigger. I mean, when we started 12 years ago, it was an evening meeting. So probably over 10 years, we've gone from an evening meeting to a 1-day to a 2-day to now a 3-day international meeting. So that's a fair amount of growth.
You're going 3-day this year? Or
so
that?
This is our 3rd year.
Right, okay. And you said the
3
meeting
days.
is soon?
The meeting is in June.
Because that's moved, hasn't it? It used to be earlier in the year.
Yeah, it used to be in January, mid-January. Then, of course, the pandemic happened.
Right.
And that has forced all meetings in the winter out of the winter. It's probably safe to go back now.
Yeah.
But once you're established then in the summer, it's very hard to go back.
Get that cycle then as well.
So, in fact, what we've done this year is we now have a second meeting in December in Melbourne. So we've gone to 2 meetings this year. So we've gone from an evening meeting to a 1-day meeting to a 2-day meeting to a 3-day international meeting to now 2 meetings a year, with the second meeting this year being in Melbourne.
Australia.
Melbourne, Australia.
Wow.
So I'm running a 2-day meeting.
To that, do you?
I'm heading there in a few weeks for a recce. We have great collaborators in the Alfred in Melbourne, and so they're helping us put this on. They're doing a lot of the local groundwork, and working very well with them. So I'm heading out in a few weeks, and then we'll be back again in December.
Excellent. What was the inspiration behind it? What drove you to start this conference? Because I would imagine it's becoming a bit of a beast now, isn't it?
Yeah, it's funny. I was just chatting with a colleague there who asked the exact same question. And in Northern Ireland, we have the Northern Ireland Intensive Care Society, or at least had the Northern Ireland Intensive Care Society. Kind of comes and goes. And when I was still a registrar, we went through one of those periods where it went, which meant we had no local meeting.
Yeah.
The website was up and running, Critical Care Reviews, and I was asked by one of my consultants, who's now a consultant colleague, would I run a meeting that we could have some CPD locally without everybody having to get into a plane and fly to London.
Yeah.
So I thought, sure, I can do that. So we did it's similar to what we're doing now 12 years later, in that we focused on the big trials.
Yeah.
So we had people from each of the local intensive care units present one of the big trials of the previous year and critique it.
Yeah.
And then someone else came along with the idea of, Rob, that's really good. Why don't you get the presenters or the trialists to come and present it? So we did that, and it's just grown. And
in the early stages, when you were asking the big trialists, if you like, to come and present, was that something they were happy to do, or
they were great?
Were they?
I remember one of the first speakers we had from outside Northern Ireland was Mervyn Singer.
Yeah.
So Mervyn got an email from someone he'd never heard of saying, could you please come to Belfast to give a talk at this meeting he'd never heard of? It couldn't be nicer. Of course, be delighted to.
Excellent.
And that's largely been the way.
Yeah. And Mervyn's a good engaging presenter as well.
Mervyn's a great engaging presenter, but he's also representative of the critical care trials community.
Yeah.
They're very, very receptive. They're very welcoming, and they're great to work with. So it's moved on from that.
So this year, you presented a lot of studies. We're not going to go through all of them, obviously. But if you could name 3 studies over the last year that you think have or will have an impact, which would you think they would be for you?
So I think Device is an American trial which compares video laryngoscopy with direct laryngoscopy in critically ill patients requiring emergency intubation, either in the intensive care unit or in the emergency department. And that showed an improvement in first pass success with the video laryngoscope.
Yeah.
So this question has been kind of bouncing around for a little while. Which is better, video laryngoscope, or should we stick with ordinary direct laryngoscopy? I think this is the trial that would push us over that line.
And did this take into account practitioner's experience, type of video laryngoscope used, situation you were in?
Yes, it did. I mean, in terms of one of the issues with these trials, and Macman was an earlier trial, has been the inexperience of some of the operators. But in the device trial, the benefit of the video laryngoscope was seen regardless of the experience of the operator.
Yeah.
Now, the degree of benefit does narrow as you become more experienced, but the benefit was seen throughout the range.
We're heading towards video laryngoscopy then, do you think?
I think so. I haven't used a direct laryngoscope in 10 years, so I probably was a little bit ahead of the evidence. And lots of people were using video laryngoscopes solely, but the evidence probably didn't support it. But I think people were comfortable with them. There certainly seemed to be no harm, and there seemed to be an apparent benefit. The evidence is now caught up, and that happens sometimes. We saw that with the triumvirate of fluid trials. Process, Promise and Arise. By the time they came through, practice has already changed from relatively wet practice to a relatively dry practice. So sometimes that happens. The trials practice already starts to move a little bit, and then the evidence confirms rather than the evidence comes first, and everybody changes then. So that's just life.
Okay, so another trial.
Let me think. Another trial. Two of the very interesting trials for the past couple of years have been classic and Clovers. So classic restrictive fluid therapy versus relatively liberal fluid therapy, and Clovers in septic shock, and Clovers is similar again in septic shock and sepsis. Liberal fluids with little vasopressor versus less fluids with more vasopressor.
Right, okay.
So which do you get the balance of? So both trials are looking at trying to give less fluids.
So when we say liberal fluids, are we talking Arise, Promise kind of liberality, or?
No, I think we've moved again. So in the classic trial from memory, it was something like at day 90, there were patients that only received something like 3.5 litres of resuscitation fluids. Okay. So they get fluids at the start. And that was in the liberal arm. At the restrictive arm might have been only 1,500 mils. I'd need to check the numbers to be absolutely sure, but very restrictive. Now, the classic protocol was very, very restrictive. I mean, people were allowed mottle before they were able to receive fluids. They were hypotensive, significantly hypotensive.
I could feel my nerves twitching.
So it's a proper trial. They really answered the question. They looked at it and they showed that the outcomes were similar.
Right.
So do we need all this fluid? Probably not. We can be very restrictive. I think what will happen is practice will probably land in between, which is, I think, what's happening anyways. We're certainly a lot less likely to give fluids than we were in the era of Rivers 15 years ago. So practice has changed. Will we become totally restrictive? I don't think so. I think we'll just be a little bit up from that. And that's kind of what was shown in Clovers as well. Not just as restrictive, but quite restrictive compared to traditional practice. And again, they showed outcomes were similar between less fluids and more fluids, less fluid supported with a vasopressor with noradrenaline. So two fascinating trials that certainly seem to show we can manage with less fluids.
So do we continue to chase fluid responsiveness, or is that something that is a bit of a myth?
I think that's a myth. I remember arguing with a certain very famous intensivist 10 years ago in America on that issue. I've never been a huge advocate of fluid responsiveness. Well, one of the issues is we didn't know the biology of fluid administration, which we're only learning now. At it properly. Fluid responsiveness, what does it mean? The cardiac output goes up for a few minutes and it comes back down, and that fluid is in. How long does it take to come out? The kinetics around it. There were so many unanswered questions. How do you actually measure fluid responsiveness? There was a lovely trial published in the BJA. It was a French trial a number of years ago, and it looked at cardiac output monitoring and how clinicians use them. And the vast majority of the time, over 95% of the time, patients for whom decisions were being taken didn't meet the criteria of that monitor to use the numbers it was generating. So there are these sorts of issues around fluid responsiveness. And the answer to that, very simply, is use a restrictive fluid technique. You don't need to give the fluids. It's been shown robustly that a lot of fluid isn't better on average than less fluid.
Yeah.
So why go with a lot of fluid, having to use, passive leg raises and stroke volume variation and all the rest, when you can just use a restrictive fluid technique, which is probably going to end up in the same place, if not a better place.
Yeah. So restricted fluid, slightly earlier vasopressors then, is that the message?
I think so. I think that's the way we've gone. Now, in 5-10 years, when someone goes and replicates Clovers and whatever else, will it be different? There's a few other interesting trials going on, Elvis and other trials looking at early vasopressors. So we'll see what they show. Remember, science is iterative. These are only a couple of trials.
Yeah.
We're only on the journey. In the same way we've gone from Rivers, Process Promise, Arise, Classic, Clovers. There's more to come.
Yeah.
So the journey isn't complete.
Is there any coming to the next conference around fluids?
No, not fluids this time round.
Okay.
So
Lovely. Well, I'm sure it'll be a fabulous conference, as it always is. Melbourne sounds absolutely lovely. It's a trip I need to make at some point, but finances permitting. But it's been lovely to speak to you, Rob, and it's lovely to meet you again.
You too, Jonathan. It's been far too long.
And can I just highly recommend the newsletter if you want just to keep track of the massive fountain of information that's coming out of critical care. You can't go much further wrong than subscribe to Rob's newsletter. It's brilliant. It just lines it up for you, and you can pick and choose the ones you want, which is what I do. Read them, analyse them, put them to one side, and then wait for the next newsletter. So thank you very much, Rob.
Brilliant. Lovely to chat to you, Jonathan.
You too.
Thank